Bismillahirrahmanirrahim. Starting our today's session with my moderator, Dr. Mudassir Hussain. So the outline of our today's session would be seminoma, its staging, prognosis, risk groups, and treatment modalities, which further includes the surveillance, chemotherapy, radiotherapy, and retroperitoneal lymph node dissection. First of all, classification, which is arising from the totipotent germ cells, is the primary tumor, second tumor, and paratesticular neoplasm. We will be focusing on the primary tumor classification, which includes the germ cell tumor, and further, which is divided into seminoma and non-seminomatous. So moving forward with seminoma. Seminoma arises from the germ cells, is the most common testicular tumor. Peak incidence is in fourth and fifth decade, with patient presents with a painless testicular mass. What are the markers which are positives of seminoma? Positive for CD117 and PLEP, and it is negative for CD30. Serum tumor markers is serum AFP is normal in seminoma, while rise in beta HCG due to syncytoplastic component, which is 5 to 10% in the seminomatous cells.
Dr. Purkani, what are the key differences between seminoma and non-seminoma?
First is the peak incidence of the tumor. The non-seminomatous germ cell tumor are mostly in 20 years to 35 years of the age, and the seminomas 35 to 45 years of age. Then the serum markers in seminoma, AFP is 95% of the time is normal, and non-seminomatous germ cell tumor AFPs are raised and in 5 to 10%, but beta ICG is also raised in these tumors.
The beta ICG raised in seminoma or non-seminoma?
Yes, sir.
Beta ICG is raised in which tumors?
Non-seminomatous.
In seminoma?
Seminoma, it is also raised, but not that significant.
And AFP is almost always raised in?
AFP non-seminomatous germ cell tumors.
Non-seminoma. Okay. Or?
Currently, I know.
Which of the two is better in terms of survival?
Seminomas are mostly better in terms of survival. They are more chemosensitive.
As well as radiosensitive?
Yes.
No, not in every case. But any rise in AFP means that this is non-seminoma. Because in seminoma, AFP doesn't rise.
Now the histopathology of the seminoma. It's macroscopically soft, tan to white, diffuse multinodular mass, and microscopically, if we see, it's sheet-like arrangements of the cells, polygonal nuclei with clear cytoplasm, and fibrovascular septi that contains the lymphocytes. You can appreciate in this picture with the large ones are the lymphocytes and syncytoplasms with positive for HCG. Now the prognostic groups for testicular cancer. On the right side, the stage grouping, stage 0, and then T, N, M, and S. Stage 0 is PTIS with N node, non-linear lymph nodes, M node, node distant metastasis, with S node, tumor markers either not studied or not available. And then stage 1 is PT1 disease to PT4 with N node, M node, and SX. The tumor markers are normal. Stage 1A is PT1 with N node, M node, and S node. Stage 1B.
Can anyone simplify this complex staging, Dr. Shirija? How many stages are there? 3, okay. So what does stage 1 mean overall? What does 2 mean and what does 3 mean?
Stage 1, 2, and 3 is the main division in which stage 1, in stage 1, there is no any nodal metastasis or distant metastasis.
So the disease is localized to testis.
The disease is only localized to testis. And then stage 1 is further divided into A, B, in which A is T1 and B is T2 to T4. And that's it. And then stage 2, in 2, there is a nodal metastasis, but there is no any distant metastasis, and the serum tumor markers That is just mildly raised or not raised at all. That is S0 or S1.
Nodal metastasis where?
So it's it's sub-classified into ABC and
No, in which region? Nodes in which region? In the neck or head or where?
okay, so retroperitoneum.
In the retroperitoneum. So in stage 1, the disease is in testis. Right? 2, disease is spread to retroperitoneum.
And in 3, there is distant metastasis or the serum tumor marker has moderately or excessively raised. That is S2 or S3.
So in stage 3, there will be pulmonary metastasis or liver metastasis or brain or bone, whatever. So this is how you can remember it. Stage 1, testis. Stage 2, retroperitoneum. Stage 3, distant metastasis. Right? So
Now, this is the staging simplified that Dr. Mudassir just now told us. Stage 1 is stage 1A and 1B, which is disease localized to the testes. Stage 2, 2A, 2B, and then 2C, which is disease spread to retroperitoneal lymph nodes only. And in stage 3, there will be 3A, 3B, and 3C, disease metastasized to distant organs like lungs, liver, bone, and brain. And in below that, the diagram is stage 1. The disease is only localized to the testicles. Stage 2, you can appreciate the lymph nodes in the retroperitoneum along with the testes. And in stage 3, distant metastasis, you can appreciate the metastasis in the lungs, liver, lymph nodes, and primary disease and the testicle.
So is there any difference between a spread of disease in retroperitoneum according to site of the testis? Right side testis disease spread to, Dr. Kamal? Which nodes, and left side which nodes?
The left side is spread to the paraortic, and the right side is aortic level and
Paracaval, right? So right side nodes paracaval, left side para-aortic in general, but there is some crossover between the two sides. Okay.
And right can go to the left and left can go to the right.
Mostly do, but there is some crossover between two in general.
Now, the prognostic-based staging system for metastatic junction tumor, IGCCCG, which divides into three groups: good prognosis group, intermediate prognosis, and
Before going to, what is the difference between staging and prognosis? We have done staging, now what is this thing, prognosis? Dr. Fazeen? Mike.
Basically predicts about the survival in a particular stage. That if the stage is one, that what would be 5-year survival rate, or what would be 10-year survival rate, and in this subsequently the stage 2 and stage 3 would have different survival rates. So prognosis basically tells.
If we want to know survival, we have already done staging. Then why we need to do this prognosis thing? That does staging doesn't predict survival?
Staging does predict survival.
But
other factors also play the role: the age of the patient, the comorbidities. So all of these factors together play a role in defining the prognosis of a patient.
So basically, staging just tells us how far the tumor has spread. It has prognostic value, but it doesn't always tell what the ultimate prognosis is going to be. Yes. So in every cancer, there are certain other factors which we use to predict the prognosis of the patient. So in testicular cancer, this is the system which we use to predict the prognosis of the cancer. Right.
Yes, though it is divided into three groups: good prognosis group, intermediate, and the poor prognosis. We will be focusing on the seminoma. In good prognosis group, there is a 5-year survival, progression-free survival rate is 89%, and 5-year survival 95%. And if you can see on the left side, all of the following criteria: any primary site, which is T1 to T4, no non-pulmonary visceral metastasis or lungs, normal AFE value, any HCG, and any LDH. In intermediate group, if you can see on the seminoma, in second bar, the 5-year progression-free survival is 79%, and 5-year survival rate is 88%. And on the criteria, any primary site, non-pulmonary visceral metastasis, normal AFP values will be there, and any HCG and any LDH. In poor prognosis group in seminoma, there's no patient classified as poor prognosis because this tumor is highly radio and chemosensitive. Now, moving towards the treatment modalities. First one is the surveillance and observation. No active treatment following radical orchiectomy, and it includes of history and physical examination, tumor markers, and computerized tomography scans. It is suitable for the selected cases of stage 1 only. What are the issues with the surveillance and observation? The issues constitutes of the compliance. Either patient is compliant or not. He can come from far away for repeatedly imaging, scanning, and history and physical examination. Extensive imaging, because we have to perform the CT scan of the abdomen to see the peritoneal lymph node extents and metastatic disease. So here he has to come from far away, or either he has a time, either for example, if he's doing a job or living a very remote area that he cannot follow or have the money to come again and again, because we have to perform the scans every 3 to 6 months, and fear of cancer progressing. Most of the time, we usually see the patients in the OPDs that they have the fear of that your cancer is moving forward and you can die early. So they usually go to homeopathic and all other remedies that are present. So this is the major issues that we face with the surveillance and observation. Now the second treatment modality for seminomas. Sir.
Is there any protocol for surveillance?
Yes, there.
For how long it will be done and what will be
The period varies from, as you said, 3 to 6 months. It's mostly 6 months. But if patient has certain symptoms or there is a rise in tumor marker, then we can do early imaging. And usually for surveillance in stage 1A, they follow up to 5 years. But depending on the patient, they may extend it. So there is no fixed protocol. It all depends on how the patient is behaving or how the things are going on.
And what will be the imaging protocol or
3 to 6 monthly imaging.
scan?
Yes.
Every
scan.
time a scan.
Yes, CT scan.
CT
Because
scan.
ultrasound cannot pick disease in the retroperitoneum, so CT will be required to pick the disease.
And tumor markers.
And tumor markers as well.
stage 1 initially start with the follow-up for the
Because mostly the recurrences occur in the first 2 years. So in the first 2 years, there will be more extensive or more closer imaging, then we can do it at later time.
then go to the per annum and same is with the stage 3. We start with the initially for the 3 and 4.
So there are different protocols.
Basically, the criteria is initially 6 months in the first 2 years, because relapse, just as Dr. Mudassir said, and then in the third and fourth year, after the 36 months, we will follow him, and on the fifth, after 5 years, one time he has to come again, and we do the imaging and all of the same physical examination on the tumor markers. Now, the other treatment modality for seminoma is radiotherapy. Basically, what is radiotherapy? Radiotherapy uses a beam of high energy rays, like we usually see in X-rays, the gamma rays and other rays or particles, to do cancer cells or slow their growth. How radiotherapy works: it targets the DNA, prevents replication of the cells, and seminomas are radiosensitive and used to treat the pelvic and retroperitoneal lymph nodes. How it targets the DNA that we have studied, there are 4 cell cycle type in the phase: G1 phase, M1, M0, and M2 phase. The radiotherapy usually works on the G0 and M1 phase. What it do, it during the transcription of the isomerase and when the replication of the messenger RNA taking place to form the DNA, it stops the cycles over the G0 phase and does not divide that messenger RNA to go forward for the DNA. Now the dose which we use in seminoma is 20 to 30 Gauss with duration of 3 to 4 weeks, every week for 20 to 30 minutes. And site is ipsilateral para-aortic nodes and iliac nodes. What are the complications that we face during the radiotherapy? Is acute gastrointestinal symptoms, like 60% of the patient face. And acute gastrointestinal symptoms include nausea, vomiting, and diarrhea usually. Chronic gastrointestinal symptoms, which includes 5%. These are the GERD that the patient have for the prolonged period of the time, and risk of non-germ cell malignancies, which usually occur in 2 to 3% of the patient, including the teratoma and others. So this is a diagrammatic picture of the radiotherapy. As you can see, there's a yellow dark line in the field. So basically yellow dark line, which is modified extended field. We usually give radiotherapy from T10 or T11 up to L3 level, which is shown in this picture. This yellow dotted line is a selective field. Like you can imagine it like when we go for an X-ray, there's a complete shield and there's a yellow light. You can see over there's a demarcation with the extensive field. But the X-ray usually come over those areas that we want to focus. So yellow is the outline. In between, you can see two others line. One is white dotted line, which regions with the no positive nodes. For example, there are no nodes available. Para-aortic field inferior border. This you can see below there. There's a dotted yellow line. This is landmark, and you can see further two different colors. One is the blue one, other one is the green one. And in the description, positive nodes for patient with right side seminoma. These are you can see in the blue line, and for the green one, positive node for patient with left side seminoma. So this is how we can focus our field on the radiotherapy. And then we have to perform 20 to 30 Gauss of the radiotherapy radiation dose for 3 to 4 weeks and 20 to 30 minutes of the time. Now, other modality for the testicular cancer is chemotherapy, surveillance, radiotherapy, and then chemotherapy. Now, chemotherapy includes different type of chemotherapeutic drugs. The first one is BEEP that we usually follow in our onco-OPDs and in our onco patients is bleomycin, Etopocite, and cisplatin. Carboplatin, EP protocol, which is of Etopocite and cisplatin. TIP is paclitaxel, isofosfamide, and cisplatin. VEIP is vinblastine, ifosfamide, and cisplatin. And VIP protocol, which is Etopocite, ifosfamide, and cisplatin. Now, the different drugs that we use, we have first one is a chemotherapeutic drug, bleomycin. How does the bleomycin act? Its mechanism of action includes a DNA synthesis inhibitor, and it's also RNA synthesis inhibitor. It is produced by the Streptomyces verticillus. Its metabolism occurs in liver, and elimination is through the renal route. Side effects includes the pulmonary fibrosis. For example, if patient come to us and he has pulmonary meds or already is a known case of any pulmonary disease, so we will do not use the bleomycin. We can have any other alternative choice for the chemotherapy. Next drug in our line is chemotherapy is Etopocite. Etopocite is mechanism of action is DNA synthesis inhibitor and inhibition of the topoisomerase. It is derived from a plant which is Podophyllum peltatum, and its metabolism occurs in liver with elimination through the renal route. Chemotherapy, other drug is cisplatin. Its mechanism include blocks the DNA transcription and replication and contains platinum. The drugs which contains the platinum are cisplatin, carboplatin, and oxaliplatin.
We use cisplatin in other cancers as well. Which common cancer we use cisplatin for as a urologist? Dr. Omer? Cisplatin is the mainstay of drug for bladder cancer. And what is the main limitation of using cisplatin? Nephrotoxicity. So in patient with renal failure, we cannot use it, or those who are at risk of renal failure, we do not use it.
The patient, those who are on risk for nephrotoxicity, for example, patient having a renal failure, how we will use this drug, for example, if we have no other choice, then there's metabolism in the renal excretion through the renal route, and side effects include the, as we discussed, nephrotoxicity. Toxic metabolites accumulate in the renal parenchyma.
There are other side effects as well, but the major limitation of using this drug is
nephrotoxicity. So how we can prevent from further deterioration of the renal function is preventing nephrotoxicity. We can have a good hydration with saline, pre and post administration of the mannitol, avoiding drug in pre-existing renal dysfunction, and close monitoring of the renal function. Now the dosage of chemotherapy. we will have three major drugs that we discuss: is cisplatin, etoposide, and bleomycin. Cisplatin is given at a dose of 20 mg per meter square with duration of 1 to 5 cycles. Etopocite is 100 mg per meter square with days of 1 to 5, and bleomycin is 30 mg days 1, 8, and 15, along with hydration. So the total days would be interval of 21 days. Now, these are the side effects of further chemotherapeutic drugs that we usually use and we have seen in our cancer patients. Common toxicities associated with the chemotherapeutic agent used to treat the germ cell tumor. Bleomycin, as we discussed already, is a pulmonary toxic. Along with that, it's also called dermatologic toxicity is not phenomena. Etoposide is myelosuppressive and secondary leukemias. Cisplatin we discussed is electrolyte disturbance. Nephrotoxicity, main side effect. Along with that, ototoxicity and neuropathy. Ifosfamide is neurotoxic along with hemorrhagic cystitis and nephrotoxicity with myelosuppression. Paclitaxel is neuropathy, myalgias, arthralgias. Vinblastine cause myelosuppression and neuropathy with carboplatin high dose, electrolyte disturbance, myelosuppression, ototoxicity, and nephrotoxicity. Along others with gemcitabine, which causes a myelosuppression and flu-like syndrome, and oxaliplatin is myelosuppression with neurotoxicity. Now, moving towards the clinical stages of the seminoma. Stage 1 is NET that we have discussed, N-node, non-regional lymph node metastasis with M-node, no distant metastasis. In this stage 1, we usually adopt the risk strategy. For example, if it is less than 4 centimeter mass with no invasion of the rete testes, it is classified into low risk, and we will have to go for the active surveillance. But it is greater than 4 centimeter or invasion of the rete testes, then it is classified into high risk group. So we have to give a carboplatin single dose and radiotherapy.
So basically, active surveillance has very limited role, only in stage 1A with low risk features. Then you can keep them on observation. Otherwise, you have to treat it with the help of radiotherapy or 1 dose of carboplatin.
Now, what are the EUA guidelines or recommendation for the stage 1 seminoma? Is to fully inform the patient about all the available management options, including the surveillance or adjuvant therapy after orchiectomy, as well as the treatment specific recurrence rates and acute and long-term side effects. Offer surveillance as a preferred management option if resources are available and the patient is compliant. That we already discussed is the patient has come to us again and again 3 and the 6 months, that we can offer him the surveillance, but we have to inform him about the chemotherapy and the radiotherapy. Third one is offer 1 dose of carboplatin at area under curve of 7 if adjuvant chemotherapy is considered. Like we discussed in the previous slide about the high risk group, if the 2 factors are available, if it is greater than 4 centimeter and involving the rete testes, then we have to perform the carboplatin 1 dose along with or radiotherapy. Fourth one is do not perform the adjuvant treatment in patient at very low risk of recurrence. No risk factor. The 2 risk factors, either it is greater than less than 4 centimeter and it is not involving the rete testes. So both of the factors are not available. It is in the low risk group. Do not routinely perform adjuvant radiotherapy, and adjuvant radiotherapy should be reserved only for high selected patients, not suitable for surveillance and with the contraindication of chemotherapy. Now, the second stage, clinical stage 2, which is NET, N1 to N3, and M0. Approximately 15 to 20% of the seminomas have clinical stage 2 disease. With first modality that we can use is radiotherapy. Reported relapse with the radiotherapy is 9%, and the radiation dose recommended in stage 2 is 30 Gauss, with stage 2B is 36. And 5-year relapse free survival includes this for stage 2A is 92% and stage 2B is 90%. There's a dose change in the radiotherapy of stage 2. Like in stage 1, we discuss the 2 other modalities, and stage 3, we have to 30 to 36 Gauss. Now, the chemotherapy for stage 2 disease is BEEP, bleomycin, etoposide, is 3 cycles, and Etopocite and carboplatin 4 cycles. And it is preferred over radiotherapy because similar efficacy to radiotherapy and lower long-term side effects.
Radiotherapy used to be the treatment of choice for seminoma, but nowadays, because of availability of chemotherapy drugs and lower side effects, mostly they are preferred. You can do radiotherapy, but mostly these drugs are available and they do it. I haven't seen radiotherapy being done. Doctor said if you have an experience of seeing radiotherapy for seminoma.
Earlier, yes, radiotherapy was done, and that was in the late 90s and early 2000. But since with the advent of this group, the medical oncologist group, it depends upon the medical oncologist, basically. The kind of drugs that are available and the kind of practice that they are doing. Earlier, we had one consultant who was trained in England. Perhaps there we found a little bit of difference between the practice from those who practice their medical oncology in England and get training in England, and those who were on the other part of the Atlantic Ocean. So there happens to be a little bit of difference in managing any kind of tumor. So for the time being, we haven't seen much of these cases for radiotherapy.
But they are still mentioned in guidelines and still written, then you can do radiotherapy, but they are not done routinely.
As an alternate.
As an alternative. But the preferred option is chemotherapy. They say it's the preferred option.
And when to give these BAP, AP, VIP, there are 4 type of medicines.
The first line is BAP. They mostly give BAP if there are no contraindications such as no chest problem, then they give bleomycin. If there are chest problem, they give EP. And if they cannot give cisplatin, then they do other drugs, which we have shown in the initial bubble. That's the domain of medical oncology.
There are side effects.
Because of side effects.
If
there are no possible contraindication, they will go with BAP, then they will go down as depending on the patient.
शक्कर वालों से भी बात करें थोड़ा.
Dr. Abbas, do you have any comment to make? We cannot hear you.
It's an excellent presentation, and he very simplified the topic, especially the seminoma, because there are a lot of controversies in this particular topic. But Dr. Jamal excellently explained and described the things. Thank you.
So, another treatment that we can use in clinical stage 2 is primary RPLND, retroperitoneal lymph node dissection. Removal of all the ipsilateral para-aortic lymph nodes provides staging as well as a therapeutic advantage. Performed only in the few centers which are highly developed, and retrograde ejaculation is a problem.
So RPLND for seminoma, is it feasible, or there are certain serious problems with using this modality as treatment for seminoma? Dr. Noman, yeah. Dr. Aslan? RPLND for seminoma and RPLND for non-seminoma, are they equal, or there is some concerns with one diagnosis and then the other? We mostly do RPLND for seminoma or non-seminoma?
Non-seminal.
We mostly do it for non-seminoma. Right. For seminoma, because they are chemosensitive, you do not mostly need it. But if you need it and you have to do it, it's very difficult to do RPLND for seminoma because there is extensive fibrosis in the retroperitoneum in seminoma patient. So in seminoma patient, you always try to do chemotherapy. You try to avoid RPLND because this is much more difficult than doing an RPLND for non-seminoma patients. And its indications are also limited. And if you have to do it, then you would first try all the chemotherapy drugs, and then you may end up doing RPLND.
But I've got a different feeling. I've got a different feeling from the angle of developing centers who can do a retroperitoneal surgery. You see, when you have got a very large, bulky, residual kind of a disease in the retroperitoneum and you want to do something which can get rid of it, then it's not, again, by definition, RPLND. It can only be debulking of the disease in the retroperitoneal area, but that is not RPLND. So if any center, a tertiary care center and a high volume center like us, who want to just go in that direction, developing the whole service, then they should start their journey from this point, doing RPLNDs, which is a template dissection on the ipsilateral as well as on the contralateral side. The template is different for each kind of a disease depending upon the tumor, whether it is a right-sided or the left-sided scrotal sac involvement. Because you see, if you're not in the practice of going into the retroperitoneum, how would you be able to develop the whole team in that direction? So it's developing the service as well as developing the team, because the dreadful complication is retrograde ejaculation. And the thing which is behind this complication is something called sympathectomy. So if you are in, the whole team is in the practice of doing a dissection which can safeguard sympathectomy, and that can only be done when there is no bulky tumor in that area, then you will develop the kind of technique and the kind of finesse that can give you this kind of a result in minimal amount of cases. But if you don't do primarily, and someone has said that it is an over-treatment, it's not an over-treatment, it is the treatment. And those centers who want to be the centers of excellence, they have to do it.
This is a flowchart treatment of the seminoma stage 2A and 2B. On one side is a clinical stage 2A that we have already discussed. With preferred treatment is chemotherapy, 3 cycles of BEP or 4 cycles of EP. If contraindication to bleomycin, like patient have any pulmonary disease, so we have another alternative, that is radiotherapy, 2x10^15 to a target dose of 30 to para-aortic and ipsilateral iliac fields, and then follow up and residual tumor to be followed. Clinical stage 2B is preferred is chemotherapy, same 3 cycles with BEP or 4 cycles if contraindication to bleomycin are present. So we have another alternative, that is radiotherapy, 20x10^15 to a target dose of 30x to para-aortic and ipsilateral iliac field, and an additional boost to the enlarged lymph nodes, which is 2x3×6. Follow up and then residual tumor to be followed. Now moving towards another stage of seminoma, which is clinical stage 3. NET, NEN, now there's M1. The disease has metastasized. In this stage, we will divide into 2 groups, either good prognosis risk group and intermediate. In good prognosis risk group that we studied or we have discussed in the previous slides, we have to give BEP 3 cycles and EP 4 cycles. In intermediate group, we have BEP of 4 cycles, and VIP, another treatment modality that we discussed, is 4 cycles of chemotherapy. And now in this stage, there's a limited role of radiotherapy or RPLND as a primary treatment. Management of the residual mass. After treatment of stage 2 and stage 3 cancers, if the residual mass is less than 3 centimeter, there is observation, which includes the imaging and tumor markers. And if it is a mass is greater than 3 centimeter, we will go for FDG PET scan. The FDG PET scan, and there's avid lesions. Repeat PET in 6 weeks to avoid the false positive results. Why there's a false positive results occurs? Because we have given the chemotherapy, and there's a desmoplastic reactions and the necrotic component that we see in the tumors. So the false result can come. So we have to wait after the chemotherapy up to the 6th week, and then we have go for the PET scan. No activity in the PET scan, then we have to observe again, and imaging and tumor markers, as we discussed the protocol, 6 months or 3 months for the observation or surveillance. Now, treatment options for FDG avid lesions. For example, if we have came across a lesion which is greater than 3 centimeter and it is active, then we have the salvage chemotherapy, salvage radiotherapy, a retroperitoneal lymph node dissection. Extensive fibrosis should be done in high volume center. This is already discussed. And salvage therapy, like I told in the initial slides, there are other modalities, VEIP, VIP, which include the paclitaxel, ifosfamide. These drugs are included in the salvage chemotherapy, which can be given in the second stage. And still, if the tumor is present on the PET scan, then we will go for the RPLN. Now, the follow-up of the seminoma testes. Recommendation regarding the minimal follow-up for seminoma clinical stage 1 on active surveillance or after the adjuvant treatment, carboplatin or radiotherapy. In modality, you can see tumor markers plus minus doctor visits is year 1 2 times, year 2 again 2 times, year 3 2 times, and year 4 and 5 once. Then in the next bar is abdominopelvic computed tomography and magnetic response imaging. Year 1 2 times, year 2 again 2 times, year 3 36 months, and year 4 and 5 again once at 60 months. And after 5 years, further management according to the survivorship care plan.
But these are not absolute follow-up plans. If patient has certain problem, then you can do imaging earlier, or if he's fine, then you may delay it.
Now the diagrammatic representation of the initial management of the seminoma. Starting from above, you can see the diagnosis based on the radical orchiectomy with pathologically confirmed pure seminoma and no elevation of AFP. Is beta HCG elevated postoperatively? We have two choices, either yes or no. If there is a no, then chest imaging and high resolution CT of the pelvis and abdomen. In this, no evidence of metastasis on the chest imaging or the CT abdomen or pelvis. Then we have no retroperitoneal lymph nodes or distant metastasis. We have only active surveillance. In the middle one, you can see if there's a lymph node involvement, then retroperitoneal lymph node involvement on imaging is stage 2, extent of the disease. Either it have lymph nodes less than 2 centimeter or greater than 2 centimeter. If it is less than 2 centimeter, low dose radiotherapy. And if lymph nodes are greater than 2 centimeter, then BEEP 3 times or EP 4 times. Now metastasis beyond the lymph nodes, then metastasis beyond the lymph nodes and lung, in advanced germ cell tumor with intermediate risk, BEEP 4 times, and in the last one is a no, then advanced GCT, good risk group, and BEEP 3 times and EP 4 times. And in the starting, if you can see, if the beta HCG is elevated postoperatively, yes, then we again follow the chest imaging and high resolution CT of the pelvis and abdomen. There's a metastasis, lungs and other lymph nodes, then yes or no, same treatment, dividing into intermediate group and good risk group, BEEP 4 times or BEEP 3 times or EP 4 times. So this is a whole treatment modality of the seminoma of the testes. Now is a session of question and answers. A 30-year-old male has been diagnosed with seminoma following the radical orchiectomy of left side 2 weeks ago. His computerized tomography scan reveals a multiple lymph node masses in paraaortic region, largest 3 centimeter in dimension. What is the stage of testicular cancer?
Dr. Abdul Razak, what is the stage of this cancer?
2B.
Another question. A 30-year-old male has been diagnosed with seminoma following the radical orchiectomy of left side 2 weeks ago, same, and his computerized scans reveals a multiple lymph node masses in paraaortic region, largest 3 centimeter in dimension. What treatment should be offered?
Dr. Hassan, what should be the treatment for this patient? Stage 2B, no?
2B.
3 cycle of BIP or 4 cycle of AP.
Yes. Thank you.